Cool. So we kick off another Friday afternoon, 5 p.m. webinar, Digital Dental Society, South Africa. And I've been waiting the whole week for this one. So today we have amongst us Dr. Sam Omar and a super special friend over and above a colleague. And a little bit of background about Sam. You know, he started off life 5 years ago in the dental industry, and he started off with 360 imaging. And, you know, his knowledge and understanding in terms of CBCT, digital workflow, just got taken to another level and another dimension. And shortly after that, he joined Megagen, who he's been with for the last 3 years. And boy, I mean, he's put together some incredible workflows for Megagen, for digital oral design, for R2Gate. But the one thing that I find unique and special about Sam is, you know, there's not many clinicians in the world that have got the capability of doing the clinical work and also doing the laboratory and the technical work on that same level. And I think that's what makes Sam so special for me, in the sense that, you know, whenever we found wanting when it came to R2Gate, Sam was the go-to guy. And as such, you know, Sam's pretty much become the global go-to guy when it comes to technical expertise behind R2Gate, behind digital oral design. So without elaborating any further, I'm going to let Sam do an introduction to himself. And then from there, we've got a super interesting discussion coming up around digital workflow. And, you know, I've said this on numerous occasions, and I'm going to say this again, is that there's been an amazing culmination of digital technology over the years, and especially over the last few years. And what that means for us, it translates into the fact that digital technology and digital workflow is now accessible to any clinician at any level without any financial investment. And that's the beauty part. So stick around through this webinar. We're gonna kick off talking a little bit more about that concept and how that has evolved and how it's mobilized so many more clinicians in the world, and how it's still mobilizing clinicians in the world to adopt clinical workflows and digital workflows into their treatment planning, and allowing them to become a lot more efficient without the financial burden behind it. So, Sam, please, once again, we're honored. We're super excited to have you with us. Please tell us a little bit about yourself.
Thank you so much, Sam. You know, what a lot of people don't know is how close Sam is to me and how close we are together. And I was unbelievably honored that he actually asked me to come on one of those webinars. So I can't thank him enough. And of course, the introduction was over the top, and I don't deserve that, not even a little bit.
Come on.
But thank you so much. And also Mark, I mean, I think everybody knows Mark. Mark is an absolutely well-known name in digital dentistry and Smile Desian, and everybody looks at what he does and learns from what he does. And he's now living in Egypt, which is absolutely great. So it's really truly an honor to be here. And I think what you guys are actually doing right now, Sam, is that especially after the last webinar, where again, we've seen so many webinars in the past, couple of months. But honestly speaking, this last webinar for me was an eye opener, and I learned so much because it tapped into a part that we really don't know much about. And there has been so many misconceptions and things that were not very clear, but people were somehow reluctant to actually come up with the information that they found, and no one shared any research that they actually did. So what happened with Marcus is that he just cleared everything. He talked about all the hot topics that people are speaking about. And I still, to this moment, I'm sharing the link of the webinar. I'm telling everybody to go and listen to that webinar because it was truly, truly magnificent. With that in mind, I have, it's like speaking after Sinatra. I really don't know what to say. So it's putting me in a really tough position. But still, I'm super happy to be here, and I just want to, especially with the topic that we chose right now, we're going to be talking about a lot about treatment planning, and I'll just share a few of my thoughts on this digital oral design concept and what is it exactly that the team has been working on for the past 8 years. It's a pretty interesting concept, and with to share this with you guys, with your digital knowledge, and with everybody that is hearing this right now, for me is just magnificent. So I can't find a better way or a better venue to share all this with you guys. So thank you so much, Sam, for the invitation.
Amazing, amazing. Thank you, Sam.
Thank you so much.
So today I've got something super interesting I want to talk about. I want to talk about mobile phones. So let's leave dentistry aside. I want to talk about mobile phones, and I'm going to take a walk through memory lane for a while, because the first mobile phone I owned was a Motorola. It was as big as a brick. I promise you, it was a weapon that I could use as self-protection. And it cost at that time a lot of money, and to run it was also super expensive. And the ability that it had was really minimal. All you could do was receive a phone call. So you look at mobile technology, and it's something that everybody can relate to, and it's something that everyone's familiar with. And over the years, it evolved in such a way that, it then got to a point that you could go out and buy really amazing mobile phones, and the applications were a lot greater. And then it got to a point, through the culmination and the development of technology, those phones got smaller and smaller and more efficient, and we could do so much more with it. But the beauty part is, we paid nothing to actually acquire it and use the technology. And as we stand today, in today's day and age, you can pretty much have a mobile phone on contract and you can pay a monthly rental, or you could have a mobile phone and do a pay-as-you-go option. And that is as a result of the culmination of digital technology. It's as a result of developments around that technology, and it's allowed access to millions and millions of people that otherwise would not afford that technology. So you look at mobile phones and you see where we are, and then you take digital workflow, for example, and you take digital dentistry, and I'm going back to the early 80s, and you look at when CEREC first came out, and I mean, they were pretty much at the forefront of that part at that time. And you look at the CEREC 1 and the CEREC 2, and the ability of the unit. Firstly, it was super expensive. Secondly, there was a super steep linear learning curve. And thirdly, the ability of the unit was very, very limited. You could do 1 or 2 surface restorations, and then if I go back, in the mid 2000s, you could suddenly do some full contour. Until today, when I speak to people, and I talk to them about digital technology, the first thing they think about is, I don't want to do my own crowns. I'm like, hang on. Let's just clear up this misconception. Digital. It's pretty much about incorporating the digital workflows and utilizing it across the whole aspect of treatment planning, guided surgery, guided dentistry, as well as diagnostics. So you look at where we stand today, and you look at the culmination of all that technology. You can go out there and you can get a super efficient, super amazing scanner for a really low fee, or you've got companies like Infinity Dentistry and 1 or 2 other companies in the background where you can actually go and rent these scanners and do as a pay-as-you-go option, or even better, you can access the technology by utilizing the laboratory that has the technology with them. what that means and translates to you is that you still do analog and conventional dentistry. You still go ahead and take an analog impression, you send it to the lab, they digitize it for you, they arrange the workflow, and all of it is done in such a seamless fashion. And this was not available to us 5 years ago. It wasn't available to us 3 years ago. But suddenly, in the last 2 to 3 years, we can see how the convergence of this technology has come together to make it more accessible. So that's where we are at. And that's the concept and the message that I want to get across today, in the sense that whoever you are, wherever you are, whatever type of practice you have, there are support structures out there that can facilitate this whole process for you without you investing a single cent. You can go onto Sam Omar's YouTube channel that he spent the last 2 or 3 months through lockdown creating some amazing videos, some amazing content to explain step by step how each of these procedures will work. You can contact me anytime, and I'm willing to share my information with you. So that being said, you know, Sam, I'm going to put the question to you this way. I know nothing about digital oral design. I'm a new dentist. We've met at a conference, or we've met having dinner somewhere, and I say to you, Sam, I want you to tell me about digital oral design. I want you to, what is it? You know, how does it work? How's it actually going to work for my practice? And I want you to take me through that process, and slowly from there, I think the conversation is going to unfold. I mean, Mark, what's your thoughts on you know, where digital has come and where it's going?
So just and guys, thank you so much for all of you. And I was just looking at all three of us and thinking, you know, there's so many similarities. You two guys have got the same name, and we've got the same haircut.
Two Sams are better than one.
But anyway, and you know, the end of the week. So this is, although this is deadly serious, what we're talking about, and so important in our lives, and will differentiate dentistry, in my opinion, like it's never been differentiated before in terms of what's been developing and where it's going. That I want to just say, and say 2 sentences, or read out 2 sentences. One of them is from a lecture of mine, but they both mean the same thing. And so one of the slides I have is, if you don't know where you're going, you'll most likely end up somewhere else, which is so true. And in fact, Christian says it in another way. He says, if you know where you're going, it's easy to get there. And that's the difference. You know, it's about planning. It's about understanding the difficulties of the case. And we were talking about, you know, wanting to spend less time in our surgeries with our patients to be more efficient. You know, that when we see the patient, you know, we want to get on with the treatment, but in the best, most precise way. And so there's no question that what we're going to talk about, or what Sam's going to talk about, is what's being delivered in this form of dentistry, the digital workflows, you know, and yeah, there's no turning back, by the way, for any of us. That's the good news. So yeah, let's get on in here. What Sam has to say.
That actually does make a lot of sense. And especially what you're saying right now, Mark, is it's really important for us to actually know where we're going. That's pretty much the key. And what we found, and us as a team, basically, when we started R2Gate back in 2012. And then later on I joined the team. But then we started to, you know, R2Gate started out as just a software that basically matches or merges all the data together of the patient, and that was pretty much it. But there was always a vision behind this software, and the concept behind it is, we always heard the word planning with implants. So now you'll find that most of the implant softwares are actually called something plan. So there was always this misconception that the word planning is only related to dental implants, but it's a lot bigger than that. And the other thing that we found was people are actually jumping back and forth between so many different softwares in order for them to do a complete treatment plan for one patient, which actually doesn't make a lot of sense. So the whole idea behind this was actually, you know, pretty simple, is that if it's possible, we wanted to work on a software that basically merges all the different aspects of planning. And by planning, again, we don't mean just implants. So what we tried to do with this platform is we wanted to put everything in the same software, just different steps in the same software. And essentially all you need to do is, get the proper information, gather the right data, and through the software, everything will be there. You could do everything you want. Implant planning is there. Cephalometric analysis is there. Head reorientation is there. Smile design is there. Basically everything you might need. And that's basically the idea. And this was the vision of JC Kim. And I have to take this chance. I have to take this chance to talk about my mentor, Dr. JC Kim. He is, I mean, it's very difficult for me to find the right words to describe this person. He has an unbelievable vision, you know, from the very beginning. From the very beginning, he's a tremendous mentor and he's a tremendous person. And everything that I know right now is actually because of him and because of the training that I got from him and all the knowledge that I learned from him. The funny thing is, Dr. JC Kim is actually trained as a periodontist. And when we meet in Germany every month for our seminars, the lecture is mainly about prosthodontics. So basically, we're giving illegal lectures in Germany. But honestly speaking, the lectures, he taps into every single part when it comes to the treatment planning. And he's a tremendous clinician. So I really, really wish at some point, one can come close to that level that he actually brings. And what I also found, and one of the things that I learned from him, is that lectures have to be educational. We see a lot of lectures right now, and we see a lot of webinars. But the key thing is, what exactly is, after you finish, and after people finish watching your webinar, what exactly did they learn? Was it only for propaganda, or was it only for show, or was it actually education? So what I learned from him is that every lecture you give has to have some educational component to it. You have to ask people after they finish, what did you learn today? And they have to come up with at least something. So it truly, truly changed the way I think. And again, I'm trying to just carry on with his message. And again, I believe that the most important thing and the most valuable thing in the whole wide world is time, more than anything else. And for people to actually give you their time and to listen to you is just beyond belief. So hopefully today we'll cover this concept of digital oral design. Whenever you want me to start, I'll just go ahead and start.
Sam, go for it. Go for it.
Yeah.
Awesome. Perfect. So let me go ahead and share my screen. And guys, let me know if you can see my presentation right now.
Perfect. Well, not, yeah, they're perfect.
Okay.
Cool.
So basically what we do, or previously, before the situation that we're in right now, we used to give monthly seminars in Germany, in Frankfurt, in the headquarters of a company named Ray. And Ray is one of our partners, and they've also developed the R2 digital oral design concept with us, because they have tremendous hardware. So that was tremendous. And these sessions are actually completely free. We do them in Germany every month. And there I lecture alongside my mentor, Dr. JC Kim. We share, lots of information. And again, it's honestly worth it to fly from anywhere in the world to listen to a whole day of Dr. JC Kim lecturing. It's really, really tremendous. So I'm super, super thankful to be able to lecture with him, even though I've lectured, quite, a good amount. But to lecture right next to my mentor, for me, is a completely different story. So just a few words for my team in Korea. I'm super thankful to my team. They've done a tremendous job. Again, ever since 2012, they've been constantly trying to develop this with the help of Megagen, and super, super happy with everything that we've accomplished so far, and we're still going. And again, this is me, this little pharaoh right here. Just as Sam said, I'm a general dentist, and I love being a general dentist. The reason why is because I'm not really trapped into a certain part, because right now I can actually do everything I want. So I love that. I'm not thinking as a prosthodontist or as a surgeon or a periodontist. I love the fact that I can do pretty much everything. So hopefully, that will carry on, and hopefully we'll gain more knowledge as we go. And the topic that we chose for today was digital oral design guidelines for full arch treatment planning. So As we said previously, digital oral design came because of the ideas that we wanted to put everything under the same umbrella. So all the things that we actually put into the software, things were like guided surgery, orthodontic cephalometric analysis, digital facial records, occlusion design, smile design, and this is all under the same umbrella, which is the same software that digital oral design or R2Gate digital oral design. And what we usually do with digital oral design, we always have to gather the right information. So we start with gathering the patient's information, and the two key information that we actually need is number one, a large FOV CBCT and a facial scan. So that's basically the main information that you need in order for you to start a full mouth treatment plan. In my presentation today, I'll only show two cases. That's all I'm going to show. This is the first case. This is a patient that came to the university as a resident in the prosthetics department. I'm a resident right now. We get a lot of cases, fully edentulous patients that come to the university and they just want dentures. So that was the patient. His name is Taha, is 55, and basically he came to the university just asking for dentures. And that's what we wanted to do for him. So he was assigned, he was assigned to me, and I wanted to start the treatment plan for him. We always start out with taking extraoral photographs. We take front photos and we take side views as well. And then we start to take the intraoral pictures. And as we can see here, it's a fully edentulous case. So he came in for dentures. For me, I'm a big implant enthusiast, so that's why I decided to go with a fixed hybrid denture. So that means that we always start out with the dentures first. We start out with the prosthesis, and then we move from the prosthesis to the implant planning. And that's what basically what we've done here. And now, because I believe the best way to do dentures would be digital dentures. But the interesting thing is, even though we call those digital dentures, what we found that most of the steps were actually done analog. And the design process is the only part that is actually being done digital. And that was my only problem with this type of protocol. So if you look at what we do with digital dentures, usually we take impressions analog, we do the bite registration analog, we establish a vertical dimension clinically, and we take the CR records clinically. We set the occlusal plane using a Fox plane, and we do that manual as well. And we determine a facial midline using a dentofacial analyzer. We do the tooth shape selection, and we do the facial record. These are all things that are actually done analog. Most of the time, we do all this analog. And basically, the only step that we do manual, that we do digital, is actually doing the denture design. So even though they're called digital dentures, most of the steps are actually being done analog. So we wanted to see what is it exactly extra that we could do digital rather than analog. And the reason why behind all this is because we believe that, again, time is the most important thing. So if you could do things, on a computer, why wouldn't you do most of the planning on a computer if you can, and just have the chair time just for the patient? And that's basically what we want. So anything that could be done digital, we wanted to do digital, and that's what we'll show in the presentation here. So we'll start with the data collection. Again, we always start with combining the data together. So we start out with a large FOV CBCT and a facial scan, and then we merge both of them together, and that becomes our basic information that we need to do the treatment plan. And we call this. Go ahead.
With your facial scan, what platform did you do that facial scan with? Was it done with Bellis 3D, or was it done with the CBCT?
Excellent. So right now, the good thing about R2Gate is that it's an open platform, which means as long as you get the data in the standard format, you could use them. In this particular case, I actually use the CBCT machine that has an integrated facial scan. And that's basically what I used here. I use in my office, or in the university as well. We use this. We use Bellis 3D. So with Bellis 3D, you can also use it on an iPhone. And in my case, I have an Android phone, so I use a clip-on camera on top, and that's what I use for the facial scan. So basically, as long as you have the standard format of a facial scan, any facial scan will do.
Perfect.
Okay. So that's as far as the patient digitization process. This is basically what we call it, joining this data together. And now a lot of people always ask, why exactly do you need such a large FOV CBCT? In the previous picture, I showed a 20 by 20 FOV. This is a pretty large FOV, but there's actually a reason behind everything that we're doing here. There's a reason why, and I'll explain this right now. So why exactly do I have to use a large FOV CBCT? 4 reasons. First thing is, this large FOV becomes the base of our treatment plan. And this is basically what I'll match everything to. All the rest of the patient's information, the facial scan, the models, the photographs, everything else matches to this facial scan, to this large FOV CBC. That's number 1. Number 2, it's really necessary for me to know where the midline of the patient is. And this is what we call the mid-facial plane determination. And to get Frankfurt horizontal plane and to reorient the patient's head. And that we'll talk about in detail right now. Number 3, it's necessary to show all the anatomical structures needed for a cephalometric analysis. And number 4, it's necessary to visualize the condyles for a digital face model. So these are basically the reasons why we have to use a large FOV. And in detail right now, I'll just go over each one of those through the functions that we have in the software. Let's start by our starting point. How do we usually start the treatment plan? Whether it was a functional case, whether it was an aesthetic case, we always start out with getting the mid-facial plane of the patient. Back in the day, or maybe until right now, we're still using facial midline analysis by using that dentofacial analyzer. This is the COIS dentofacial analyzer. And basically the idea is I need the lab to also know where the midline of the patient's face is. Because we always know that the dental midline and the facial midline do not always correlate together. They're not always the same. So we need to know exactly where that is. But this process is being done analog. Is there any way we could do this same process, which is determining where the midline of the patient's head and adjusting the patient's head, but do it digital to save ourselves a little bit of time? And that's actually what we do. So inside R2Gate, what we do is we will get that large FOV CBCT, regardless of how the patient was scanned. We can, in the software, digitally realign the patient's head to adjust it and to get exactly where the midline of the patient's head is. Not only from a frontal view, but also from a side view. So for instance, if you need to get the patient's natural hip position, or if you need to get Frankfurt horizontal plane, especially Frankfurt horizontal plane, because we'll talk about this extensively right now, through this function, you could actually do that. And again, this is something that could be done in a computer. If it can be done in a computer, just do it on the computer and save yourself a little bit of time. Now that we do that, so we have the facial midline analysis, we go from here. This is how the patient was scanned at the beginning, to adjusting his head to look like this. And we can also look at the patient's soft tissue profile. And that's the good thing about having a CBCT, because it also allows you to see the soft tissue of the patient. We move from here to we get this, what we have in front of us right now. So that's the proper head reorientation. And that's always the starting point for our treatment plans. So that's good. Now that we got our information, I'll tap into something else, which is cephalometric analysis. And I know we don't have a lot of orthodontists here. And the misconception is cephalometric analysis is something only for orthodontists. But let me tell you about this. When and why do we do a cephalometric analysis in general? Let me talk to you about this particular workflow. We do the cephalometric analysis within the R2Gate software at the beginning of each case. And I'll explain why we do this right now. So we do it. The reason why is because we want to know what skeletal relationship does the patient have, and also to get references and angles that will help us determine the vertical dimension and to set the occlusal plane. I'll go into details in this, but let me walk you through this step by step. So number 1, let's talk about determining the skeletal relationship through cephalometric analysis. And why would I need to know the skeletal relationship of the patient? Because we all know that your treatment plan will change drastically because of the patient's skeletal relationship. I don't treat a class 1 patient just like I treat a class 2 patient, just like I treat a class 3 patient. But that's super, super, super important. You guys as prosthodontists really know that, but not everybody else does. So let's talk about the importance of knowing that skeletal relationship and how we can actually do that. So let me talk a little bit about cephalometric analysis, just very briefly. And I'll tell you just very few information. Number 1, we have to know just few landmarks in order for us to understand what the skeletal relationship will help us with. First point that we need to know is a point called Desian. So this point is right here, and it's basically the frontonasal suture, the front point of the frontonasal suture, this point right here. So that's the first point that we need to learn today, endpoint. What is the importance of this particular point? So in order for us to know what the skeletal relationship of the patient is, what we usually do is we take a line, and this line runs down and is perpendicular to Frankfurt horizontal plane. So if you look at the picture that we have in front of us, this line right here on the right side is going straight through Desian and is going perpendicular to Frankfurt horizontal plane. And through that line, we'll be able to know what the skeletal relationship of the patient is. This line, by the way, is called either Desian perpendicular because it runs from Desian perpendicular to Frankfurt horizontal plane, or it could be named McNamara line. Whatever name it is, McNamara line, Desian perpendicular is basically the same thing. That's the first point that we need to know. Let's talk about the second point we need to know. Second point that we need to know is A point. And what is A point? A point is this point right here, and it's basically the deepest point in the maxilla. Okay, the deepest point in the maxilla, or the deepest point of the concavity in the maxilla. Why do I need to know this point? Number one, it actually helps us to relate the maxilla to the cranial base. So it allows us to know if this patient's maxilla is normal, if it's protruded, or if it's retruded. Okay, very good. So what's normal? In order for us to know what's abnormal, we need to know what is normal. So normally, the McNamara line, or this point, A point, is actually on that line, on the McNamara line or Desian perpendicular line. Okay, which means that if A point is ahead of the line, you'll get a positive measurement, which means that the patient's maxilla is actually protruded. And if it's behind the line, you'll get a negative number. So that's basically what that is. So if we look at the images on the right side, we have two images, one on the right side, far right side, and one right next to it. The one on the right side says -4. So the distance between point A and McNamara line is -4, which means that this patient's maxilla is retruded by 4 millimeters. If we look at the image on the left side, it says 5, which is +5, which means that in this case, this patient's maxilla is protruded by 5 millimeters. So just by knowing these little information, we'll be able to know what the skeletal relationship of the maxilla is. Now, what about the mandible? Let's just know one point in the mandible that is really important, which is PG point. And what we call it Pagonian point. PG point is the most anterior point in the mandible. So what does this help? How does this help us basically when we're doing that? This point allows us to know what the relationship of the mandible to the cranial base is. So we know if the patient is class 1, class 2, or class 3. Again, if the point is in front of the line, basically we'll get a positive measurement. If the point is behind the line, we'll get a negative measurement. Normal for a woman is -4 to 0. And a normal for a man is -2 to +2. Again, because men have more prominent chins, so basically you'll get a more positive number. So let's get an example. So if you look at the right side, let's look at this image right here. On this image on the left side, you'll find that this patient has a 0, zero number from point A and also from Pagonian, which means that this patient has a normal maxilla and a normal mandible. On the other hand, if you look at the image on the right side, and if you see how far point PG is from the McNamara line, you'll find that it's -31 millimeters, which means that this patient has a severely retruded mandible. So this is all great, but how does this actually help us when we're doing a treatment plan? And this is basically what I'm getting to. Now, if you're discussing the treatment plan with your patient, let's say you placed a few implants, and that's the difference between people who actually plan their cases and people that don't. So let's say you place the implants, you send everything to the lab, you send the impressions to the lab, and then the lab mounts everything together. And what they see is that the mandible is here and the maxilla is so far to the front, which means that the patient does not have a normal skeletal relationship. So basically what they need to do is they need to do an FP3 type of restoration. On the other hand, a lot of our patients are actually not okay with seeing any pink into their mouth. And if you look at the patient on the left side, this is a normal skeletal relationship, which means that in this case, I could do the simplest type of restoration, which is an FP1 type of restoration that is normal crown and bridge type of prosthesis. So that's really, really, really important for us to know, because if I discuss that with the patient before, and that's what differentiates what we call an expert from what we call an excuser. If you know what the skeletal relationship of the patient is, you will tell the patient beforehand that you'll be doing this type of restoration. I'll do an FP3 type of restoration, and you'll have some pink, so the patient is actually prepared. And you discuss that with the patient beforehand, and that's the key for you to get success towards the end. So that's why we need to know what the skeletal relationship of the patient is. Are we good so far?
Good.
Awesome. So the good thing about R2 Gate is that it actually allows you to get all these readings automatically. So now that you just place the points in the software, and the software gives you exactly where to place the points and lets you know where to place them, it gives you an automatic reading from the distance between McNamara line and A point, so you know what the skeletal relationship in the maxilla is. And it gives you an automatic reading between McNamara line and PG point, so you know what the skeletal relationship of the mandible is. And if we look at the patient, this patient on the right side, due to the readings, we have 5 on the top, so we have 5 millimeters protrusion, and on the bottom we have 4 millimeters protrusion. So this patient, as we can see here, has bimaxillary protrusion. So it's really important for us to know this information. That's the first thing that we need to know. Now let's talk about establishing a new vertical dimension. We usually establish the vertical dimension in the patient's mouth, and that's the process that we've been doing for years now. But we don't really have any way in order for us to confirm what the proper vertical dimension is. So it might look right, but I'm not 100% sure if it's correct or not. Is there any way we can confirm that this vertical dimension is actually correct vertical dimension? And that's why I'll talk about cephalometric analysis also, because cephalometric analysis has so much information that we could use for that. So to verify the vertical dimension of the patient through that cephalometric analysis, which again is done automatically, we have what we call y-axis angle, which is this angle right here that I just highlighted. This y-axis angle in Downs analysis is actually 59 degrees, which means that the normal for a Caucasian patient is actually 59 degrees. And if I look at the patient that I have in front of me right now, it's actually 48 degrees, which means that in this case, I might need to open the vertical of the patient a little bit. So again, it's a very nice way for you to actually confirm if the vertical that you have is actually correct or not. So that's the key thing that we use cephalometric analysis for. One more thing, like setting an occlusal plane. Now, if we do a denture, what we usually do is we use a fox.
Sorry, I want to stop you for a second, Sam. I mean, sure. Mark, you know how difficult it is in those edentulous patients to actually get to the right vertical dimension, and how challenging it could be to actually go in with multiple trines if you pretty much start from scratch. And I think that's something that we need to highlight around the software, because realistically, there is no other software out there that can do it at that level that I'm aware of. So I think it's one of the key differentiators, and like when we've worked on it in the lab as well, it really has been like a significant standout over other ways of actually designing it. So yeah, I just wanted to make a comment regarding that.
And again, the key is we just need to know what the angles that we get mean. That's pretty much all we need to do. As long as the software will do this automatically for you, the key is just understand what each angle means and you'll be good to go. And that's what we're explaining here. So we talked about y-axis angle and how through y-axis angle, which you get an automatic reading for in the software, allows you to know what the proper vertical dimension of the patient is, and if you need to open or close the vertical of the patient. So that's pretty good. Now let's talk about occlusal planes. Again, if we establish a new occlusal plane for an edentulous patient, we usually use something like a Fox plane. And this is basically what we normally use. The idea behind a Fox plane is that this device, we put this part inside of the patient's mouth, and this part is extraoral. And through that, we look at the patient from a facial view. And if that Fox plane is parallel to the interpupillary line, it means that the occlusal plane is correct. And if we look at the patient from a side view, and we look at the patient, and if this occlusal plane that we have, or the Fox plane, is actually parallel to the iliatragus line, it means that this is probably the right angle of the occlusal plane. So that's basically is the easiest and the most commonly used way to get an occlusal plane. I have just a couple of problems with this particular workflow. Number one, the Fox plane method gives you a flat occlusal plane. And we all know that occlusal planes are not flat. We have the curve of Spee, the curve of Wilson. And in order for us to actually compensate for this, when we set the teeth, we set them in a way so they're not flat, which means that the operator or the dental technician, or if you like to do your own setting, it means that you need to know which teeth are actually on the occlusal plane, which teeth are below the occlusal plane. And that's, it's really, really important for you to understand this information so you can set a proper occlusal plane. And that's, it really dependent on the operator. So that's a little bit of a problem for me. The second thing is, the Fox plane method is subjected to operator error. Let's say, for instance, if I put the Fox plane into the patient's mouth, I'm not having a good day, maybe I'm not seeing things perfectly, and it's a pretty subjective method. It's not the best way for you to actually get the occlusal plane, and that's why sometimes we end up with canted occlusal planes in the dentures, just like we have on the right side. So, again, what is it exactly that we could do? And if we think about it, if the occlusal plane is not flat, what would be an ideal looking occlusal plane? So ideal occlusal planes, the natural, the God-given occlusal planes, they have curve of Spee, they have curve of Wilson, and we always have a midline that allows us to know, that gives us a reference. So if we put this all together in a digital occlusal plane, what would that look like? And that's basically what we created. This is what we have in front of us right now. This is the digital occlusal plane that we're actually introducing into that digital oral design or Artogate workflow. This occlusal plane has a curve of Spee, it has a curve of Wilson, and it has a midline for reference, and basically it gives you all the information that you need. And it's all in one STL file. The good thing about having this information digital is that you can just drop it into the software, and that's basically what we're doing. You could adjust the level of the occlusal plane, you can adjust the angle of the occlusal plane, or the level as we can see right here, and you could clamp the occlusal plane and do whatever you want with the occlusal plane. You could adjust it again, and you could do this extremely easily, and you don't have to do this with removing wax, with adding wax. It makes your life a lot easier. And again, this is one of the things that people are used to doing in the patient's mouth. Why not do it on a computer? And that's what we're trying to do right here. So what we saw here at the beginning of the video is I showed you that I'm moving the occlusal plane up and down. So what exactly is the right angle of the occlusal plane? Is it here? Is it here? Is it here? Which exactly is the ideal occlusal plane? That means that we actually also need a reference. So that's what we're doing. We're referring back to the cephalometric analysis, because also cephalometric analysis has something that is very helpful for us, which is what we call the occlusal plane angle, which is this angle right here. And again, the software gives you an automatic reading of this. So in Downs analysis, the occlusal plane angle is actually 9.3 degrees for a Caucasian patient. And that's basically the information that you can verify through the cephalometric analysis. And see, someone like me, I never used to use...
I'm going to stop you there 1 second, Sam. 1 second. Sure. When you take your CBCTs for edentulous patients, right?
Yes.
Do you do it with the wax rim in the mouth for stability?
Definitely.
And reference vertical dimension?
Definitely. So basically what we do, clinically, we do an estimated vertical dimension. You don't have to spend too much time on establishing a vertical dimension. Just get your centric relation with a Gothic arc tracer, which is basically the best way, and get vertical dimension, which you think is correct. Now I scan the patient wearing the wax rings, and then this is, because I need to have the patient in centric relation and in the estimated vertical dimension. And after that, I can actually verify those through the software. So what the software is helping you do right now is it's helping you verify the vertical dimension that you've already established. So that's basically
Can I ask you one question? So
sure.
I mean, it's amazing, obviously, to use the angles and the numbers, but and obviously the vertical is the vertical. But obviously, what's really key at this point, if we're deciding, or maybe you're going to get to that we have to also then decide where is the edge of the upper central incisor going to be, because obviously the vertical, can be this amount or whatever it is, but the incisal edge can vary tremendously depending on soft tissue.
Absolutely,
So
absolutely.
at what point are you determining the incisal edge position? Is that still coming down the line, or?
Absolutely. So usually the way we do this is we have two methods. So sometimes we use the soft tissue cephalometric analysis, and through soft tissue cephalometric analysis, we use a point that is called stomion, which is basically if the patient brings their lips together. Through this point, we go back about 8 millimeters, and this is how we determine what the position of the central incisor is. And as Mark said, determining the position of that central incisor is key for you to know what the proper position of the rest of the arch will be. Go ahead, Mark.
So I'm jumping the gun a little bit here, Mark, but what you can do is you can pretty much take your DSD design and bring it into the software as well. So you can take your DSD once you've established it, for example, and bring it into the software and vice versa.
Yeah. Okay. No, I mean, obviously, at some point you have to use the soft tissue to guide the central incisal edge position, which would be then not the starting point, but it's an important point to have referenced as early as possible, I think, in all planning.
And definitely, it's super important for us to actually know what the position of the central incisor is, because if you know where the position of the central incisor is, basically you can set the rest of the teeth. So that's a super important part. And that's why we use cephalometric analysis for that, and we use hard tissue cephalometric analysis for that as well. So these are the key points that we need for us to actually start the treatment. Now that we're done with setting an occlusal plane, again, that digital occlusal plane that we set, let's go ahead and move on to the next point. One of the things that we also do when it comes to full mouth rehabilitation is what we also get a faceable record. And again, the idea behind a faceable record is that it's a tool that allows me to move the patient and have the patient in the articulator, and it gives us the most accurate replication of the movement that happened in the patient's mouth, but in the articulator. So again, just to reiterate, what we're doing is we're putting the patient in the articulator. So what we wanted to do in this case is we wanted to do things a little bit differently. And what we wanted to do is, instead of putting the patient in the articulator, why not put the articulator in the patient through the Artogate software? So that's what we're doing now. Now, what is the point that we need to get into the software? So basically what we need to get is this point right here, which is the hinge axis of the articulator. The hinge axis of the articulator is basically the condyle of the patient. So what we do is we get this hinge axis of the articulator and we digitize it. And what we do is we move that as an STL file and we drop it into the software. And if you remember at the beginning, we said that we get a large FOV. And one of the reasons why we do that is because through a large size FOV, you can actually see where the condyle is. So all you have to do is just match that hinge axis of the articulator to the condyle of the patient based on the reference line that we have in front of us right here. So basically the idea again is that why put the patient in the articulator if you could put the articulator into the patient, and now we have all the information of the patient. Now when it comes to mounting the case, we use this line. Do you guys see this blue line right here? This is Frankfurt horizontal plane. So this is basically what I use as a reference in order for me to put that and to digitally mount this into the articulator. And I will go into detail into this part just in a few minutes. So now that we've done that, and also digital facebo or facebo in general is something that we do clinically. If you could do it digital, then why not do it on a computer? Next part would be Smile Design. And again, in the same software, all these steps have been completely done in the same software. So for that same patient, we've done that Smile Design. And instead of doing a two-dimensional smile design, we've done a three-dimensional smile design to begin with, utilizing that facial scan. So through the facial scan, and the reason why we advocate using facial scans is that it's a more dynamic tool than a picture. And again, with the three-dimensional facial scan, you don't have the issue with the yaw and roll and pitch, which is basically if you take a wrong patient or if you do not position your patient correctly, it becomes a little bit of a problem later on. But because you can use a three-dimensional facial scan that is a little bit more dynamic, it allows you to do a three-dimensional smile design. The three-dimensional.
So Can I ask one question? When
Sure.
you do the facial scan, do you have a specific scan that you ask for, like a full smile or half smile or a open mouth, or
Yes.
you know, what are you looking for in a facial scan? Obviously, in photography, you know, we have protocols, but in facial scanning, if you're introducing the software, what would be your ideal kind of static position of the face?
Excellent. So we usually do 2 facial scans. The first facial scan will be a normal facial scan of the patient, which is basically what we use in order for us to match this facial scan to the CBCT. That's the first facial scan that we use. So we scan the patient exactly the same way he was scanned during the CBCT. That's number 1. And then we do another facial scan, which is a maximum smile facial scan. And we use this particular facial scan to do the smile design. So we match this to the first facial scan that was already matched to the CBCT. And again, the second facial scan is a maximum smile facial scan. So we get the maximum smile of the patient through that scan. Okay?
Yeah, good.
Awesome. So that's basically what we do right now. And the good thing is, everything inside the software is now exportable. So I can export that 3-dimensional smile design that I've done, and I can export it out of the software with the same position. So it allows me to use whatever software I want to actually design the teeth. So let's move on to the next part. I've designed my 3D smile design. I went ahead and I exported that. And in this case, actually, we had, before I actually did this case, I was in a visit in the Netherlands. And I visited the guys at Avident. You guys know what Avident is? It's one of the biggest companies that do digital dentures. And for me, the interesting part is that they still receive a lot of data from doctors that are actually physical data. So we had a challenge in this case, is we asked them, you know, let's have a bet that will actually send all the information of this case completely digital. And you guys are in the Netherlands, I'm in Egypt, let's just go ahead and send all the data here digital. And that's basically what we agreed on. So the information that we actually sent to them, this is everything that we exported out of the treatment plan. We exported the upper and lower model of the patient. So this is the upper model of the patient. This is the lower model. And again, they're in the right vertical dimension. We exported that digital face bow that we took with the reference Frankfurt horizontal plane. And that's what they will use to do the digital mounting. We also exported the smile design that we've done. This is the smile design that we've done for this patient. And then we exported the occlusal plane. So basically, for a lab technician, this is everything they need to know in order for them to actually design a denture. They have the fitting surfaces. They have the shape of the teeth that looks good on the patient. They have information about the midline. And they also have information about the occlusal plane. So this is all the information they need. We sent all this data digital to Avident in the Netherlands, and then they started out their process. The first thing that we do when you get the models of the patient is that you mount them. But instead of doing this mounting procedure manually, we did this digitally through a digital mounting process. So that was the first step in order for us to start the design process. Next was, after they finished the design of the denture, they sent me a project file. Basically, what everything is in blue is basically the information that I sent for them. So this is the information that I sent for them. And then based on that, they just filled in the rest of the information. So they filled in the denture base, what we can see here. They copied the same shape of the teeth, and they copied the same midline, and they followed the information from that occlusal plane that we sent. The good thing about this information is that it's very, very easy, you know, to read. And there's no interpretation here, and interpretation actually leads to a lot of problems. This is very clear. You know exactly where the midline is. It's a straight line. You know where the occlusal plane is. It's a curved line, and all you need to do is just, with the design of your teeth, just follow basically what you have in front of you. So it makes their design process a lot easier. And from what I got from them, they said this was the easiest denture they've ever made, because the information for them was extremely clear. And that's what we want to do. Now, when it comes to the manufacturing process, I gave them the A-OK. Everything looks good. Let's just go ahead and start to design to actually manufacture the denture. They have a very nice protocol. What they do is they mill monolithic dentures. So what they do is they manufacture a specific puck for every patient. So basically, when you mill that denture, it becomes a monolithic denture because you don't need to mill two parts of the denture. You don't need to mill the teeth on their own.
Sam, I want you to highlight that again. I want you to highlight that point again.
Okay. So basically what they do, they have a very cool protocol when it comes to the manufacturing. They believe in monolithic dentures. They have two-piece dentures and monolithic dentures, but they believe that monolithic dentures is actually the way to go. So what they do is they design the denture first, and then they go through a specific manufacturing process where they manufacture a puck or a disc for every patient. And that's the key part. So you see this disc right here, it has both the white part and also the pink part in the same puck. And based on that,
what material is that, Sam?
this is PMMA. This is cross-linked PMMA.
Okay.
Okay. So then they start the milling process, and again, this is a monolithic denture. And according to them, this is 5 times stronger than a standard denture, which is basically what we use, and we glue the parts together because this is all one piece. So that's the good thing about their manufacturing process. It's extremely neat. It makes a lot of sense, actually. And that's pretty much it.
Amazing.
And
so just a question. The tooth part, is that kind of monolithic in its color, or is it possible to kind of do a multi?
It's actually multi-layered, and that's the very cool part.
That's very cool. A multi-layered.
You know that the interesting thing is when I got the denture from them, I did like the YouTubers do. I did a complete unboxing experience. So really, because the denture looked so good, I couldn't believe how good that denture looked. So they sent me the denture in a box. I was in Frankfurt at the time. We had one of our seminars. So I did the unboxing experience. I opened the denture. This is how it looks like. This is how the packaging looks like. It's extremely cool. So the way they even packages, it looks really nice. And if you look at the denture, let me show you the upper denture. The interesting part is how the color is actually graded. So if you look at the incisal translucency on the bottom, you can actually see that the colors are actually quite different, and it looks tremendous in the patient's mouth. Now, one of the other things that we agreed on is that we're not going to do any try-in. We'll jump from design to delivery right away, and that's what we did. So I went back to the university. This is a university patient getting an international denture. So we gave him the denture. We tried the denture in the patient's mouth, and I was, even though a lot of people had their doubts, it was extremely retentive and extremely stable, which I really, really love. And again, for you the first digital denture experience for you is either a make or break. It could be a good experience. It could be a very bad experience. Luckily, in this case.
So Sam, just to highlight something.
Yes.
Two questions. From start to finish, how many appointments did you see the patient for? That's the first question.
I saw the patient for primary impressions, for secondary impressions, and for bite registration. And basically for the final delivery.
So just to unpack, that first appointment that you saw him is where you've acquired all your digital information. You got your CBCT, your FRV CBCT, you've taken your primary impressions, you've taken your face scan,
correct,
and all the processes started in DOD, in digital oral design, in the actual software. You went and unpacked that. Then a couple of days later, you pretty much did your secondary impressions.
Okay, so basically, I get the information of the patient. I get all the scans in the third appointment. So I do the primary impression, I do the secondary impression, and then when I do the bite registration process, and then I send the patient to be scanned wearing the bite registration. So that's the key part. That's how you get the patient to be in the proper vertical dimension and the correct CR. That's how you could get the rest of the information, where you could do the digital face bow, you could do the cephalometric analysis. So you need to make sure that the patient is scanned in the right vertical dimension. And that's why we always do that in the third appointment.
100%. So I just want to unpack that again.
Yes. So the first couple of appointments are just standard. We take the upper impression, take your primary impression. second appointment, secondary impression, third appointment, bite registration, and acquiring the rest of the data. Then I leave the patient home for a little while. I do my planning on the computer. I finish everything that I can on the computer. I send the design to the guys that do the design, do the manufacturing, send it to me, and then we go ahead and we do the delivery right away. So the key is you have to scan the patient and acquire the data while the patient is in the right centric relation and the estimated vertical dimension.
Great.
Okay, now, and this is what we went through. This is how the patient came into the university. This is how the patient basically looked at the time of the delivery. But remember that what we agreed on in this case is we're going to do fixed hybrid dentures. So that was only the beginning of the treatment plan. But the reason why this is the most important part, because placing implants is not a big deal. The whole, all the planning is in the previous stages. This is where the tough part is. This is where you need to get all the right information. So
prosthetically driven, once again, prosthetically driven implant planning.
That's basically what we need. We need to make sure that we do everything prosthetically driven. And that's what I'll show you right now. The good thing is, I know that the denture fits really well. The phonetics are good. The aesthetics are good. The patient is happy with the denture. Function-wise, everything looks good. Now, this gives me the green light to move on to the next part of the treatment, which is basically placing the implants. Now that I have all the information from the denture, I can now plan the implant positions based on the positions of the teeth in that new denture. And by the way, I don't need to take another scan. As long as all the information or all the data are in the proper position, as far as X, Y, Z positioning or the coordinates of the files, I could just input the data in and I'm good to go. So now I planned all my implants. I know where to plan straight implants. I know where to plan tilted implants. And in this case, I planned 6 implants in the upper and I planned 4 implants in the lower, which is basically what's recommended. The good thing about R2Gate is, again, everything is exportable. So I can export the data from the treatment plan to them. So what I did was I exported the implants. I exported the angled multi-unit abutments, as you can see here. And the reason why I did that is because the next step will be to do a denture that is ready for conversion. So what I need them to do for me is I need them to open holes in the denture where the prosthetics will fit. That's basically...
I just want to stop you there. For people that are not familiar with how the R2Gate labs work, I just want you to make reference to yourself, R2Gate lab, South Korea, how it actually moves from one part to the next, and how, or that sort of communication channel. Because the thing that I want to get across is, for a dentist or for a specialist that's actually watching this webinar today, he goes back to his practice on Monday. Where does he start, and how does that communication channel actually work, and the role that South Korea and the MegaGen Planning Center actually play in facilitation through the laboratory, and what the laboratory's role is back to the actual clinician.
Excellent. So the good thing is, right now in South Africa, we actually have 5 planning centers. So we have an R2Gate planning center in Johannesburg. We have 2 actually in Johannesburg. We have in Durban. We have in Cape Town. So basically everywhere in South Africa, there is actually a treatment planning center, or R2Gate treatment planning center. All you need to do is just send them the information, send them the CBCT scan, send them the models of the patient, and then they'll do the whole treatment plan for you. The key thing is you just need to know what the information to send are. That's all you need to know. And towards the end of the presentation, I'll reference the playlist that we've made in order for people to know what the concept of digital oral design is, what the right data to send is, what the proper scanning protocols are. That's, we'll cover towards the end. And the cool thing is, my last travel was actually to South Africa. So I was in South Africa in March, and we did a full digital oral design training to all the R2Gate centers in South Africa. So that was pretty good. So the guys are all fully trained. They know how to use the software, and that's pretty much it. For me, I like to do everything myself. But again, not everybody likes to do that. I like to do the surgical part, the prosthetic part, the lab part. I enjoy doing that. But again, not everyone likes to do the same thing. So
100%.
we need to do this.
So just to interrupt you there, we're running out of time a little bit, so we just need to try and round up this first one. I know that you had another case, but we're going to do another webinar to go through that. And yeah, I just want to leave some time at the end to unpack one or two questions and just to get that channel right again.
Awesome. So let me go back to this presentation. Yeah. So again, as we said, the next step right now would be to start to convert the standard denture to a digital denture. Actually, to a fixed hybrid denture. I did not use the same denture in this case. It's basically the same design but a different denture. This is the protocol that we agreed on. The reason why is because you always need to have a backup, because you never know, even if you plan the implants and place the implants, you never know if you still get the ISQ that you need, the insertion torque that you need. So it's always a good idea to have a backup. And the backup was the status quo, was the denture that the patient is already happy with. This is just a copy of the denture made with the same material. But this denture was made and it's ready for conversion, basically. So you have holes in the denture that basically will correspond to where the implant positions are going to go. And that's basically how that looks like. Now, the only problem is if you place a lot of implants, like 4 implants and 6 implants to a patient in one appointment, towards the end of the appointment, if you ask the patient to bite again in centric relation for you to do the pickup, it's really, it's quite tough for the patient because the patient is usually very tired. So how exactly can we bring the patient to bite back in centric relation every time when we try to do the pickup? So that's why the guys at Avident, they developed this occlusal lock right here. You see this little ramp right here. The idea behind it is that every time the patient bites down, it just guides him to go back in centric relation. So when you do your pickup, nothing changes with the occlusion. The occlusion always remains the same. And that's the idea behind this occlusal lock. So it's a very smart idea. Now, again, because chair time is very expensive time, we wanted to make sure that whenever we go into the surgery, we have everything ready. So what I need next is to know which multi-unit abutments to use, which cuff height. I already know the angles, but I need to know which cuff height would be the best. And I also need to pre-cut the cylinders that fit on top of the multi-unit abutments, in order for me to save time rather than cutting them in the surgery. Can I cut them beforehand? Yes, and that's what we did. So we designed a digital model before the surgery, which corresponds with the future implant positions. And that's, again, one of the things that we can export from R2Gate. You can export a model that you could use in your CAD software to design this digital analog model. We selected the cuff height based on the soft tissue information, and then we put the multi-unit abutments, we put the cylinders on top of the multi-unit abutments, and we cut them. After we cut them, we put every cylinder in a sterilization pouch named after the implant that is being placed. So basically, all you need to do is place the implant, get the pouch that corresponds with the number of the implant, place that cylinder on top. And that's basically what we went in the surgery. Designed my R2Gate surgical guide, and now I'm ready to do my surgery. We did this. This is obviously a tissue-supported guide. We placed anchor pins to support the guide on top of the tissue. We did the drilling guided, and we used the 50-50 drilling protocols, which means it's a 50 Newton centimeter torque, 50 torque, and basically a 50 RPM. And also the implant placement was done fully guided through the surgical guide. Now, in the anterior area, we had a little bit of extra bones. So we wanted to do a little bit of bone reduction. I did the bone reduction after I placed my implants. So I completed the implant placement, and every additional procedure was actually done after placing the implants. We measured ISQs. We made sure that all the ISQs that we got are actually sufficient for us to do immediate loading. At this point, I still didn't know, before I measured ISQ, if I will do immediate loading or not, because immediate loading needs to be done based on criteria. And these criteria are insertion torque and ISQ. And then we placed the multi-unit abutments, we placed the cylinders, we suture everything up. And this is basically how the conversion looks like. Done the conversion using bisacryl, and we removed all the flanges of the denture. So the denture is a lot thinner and a lot, it's a lot better for the patient right now. This is how the converted denture looks like. The next week, we did the upper surgery. This is how the lower looks like. When the next week we did the upper surgery, we placed the denture as well. Again, we did the drilling, fully guided. The implant placement was fully guided. We even had a couple of implants that were planned in the sinus. So as long as we're doing everything guided, why not do a guided sinus lift? So that's what we agreed on. And together with Megagen, we developed this kit in order for you to use the Versa Guides guide, the Versa drills guided, the osteodensification burst. So these extenders that we're testing right now allow us to do completely guided sinus. So that's what we used in this case right here. So yeah, this is the kit on the right side, and these are the burrs on the left side. So even the bone delivery, even delivering the bone, we did that guided as well. So we placed that through the surgical guide. As long as everything is being done guided, why not do the bone delivery through the surgical guide as well? So we actually did that. We packed the bone through the osteotomy, and we placed the implants through the surgical guide, nice and fully guided. Just to confirm that everything went well with the procedure, we took a post-op CBCT, and this is how the bone looks like. This is how the bone looks like after the sinus lift procedure on implant number 16, and this is how 26 looks like. So we confirmed that we did do a successful sinus lift. Measured ISQs. After we measured ISQs, we went ahead and did the placement of the multi-unit abutments and the cylinders. And if you look at them from a top view, it looks like they're completely parallel, and that's basically what we want to make the procedure a lot easier. To do the pickup, we just place the rubber dam underneath all the cylinders. We do the pickup in the patient's mouth while the patient is biting down, while the patient is eccentric, because we don't want to change the bite of the patient. And we just we open very tiny holes on the buccal side, for those who are wondering, just to inject the bisacril through that. And then after we finish, we just add a little bit of flowable composite. Anything else that you need to do after this point, you could do. So if you need to do a little bit of augmentation, you could do that after you place the implants already. And then we completed the conversion process. And again, no palate. We converted all the inner surfaces of the guide. Instead of them being concave, we had them flat. And then that's just basically to avoid any food from going underneath the denture. And this is how the denture looks like in the patient's mouth. This is how the bite looks like on the right side, on the left side. We maintained everything. And this is a 1-week follow-up after the surgery. This is a 1-month follow-up, and the healing looks quite good. And this is a 1-month follow-up intraorally of the patient. And this is how everything looks like. What is underneath is just we're adding composite as we go, just flowable composite to make sure there's nothing seeping underneath the denture. That's basically what we're able to do. So we went from a fully edentulous patient to a completely edentulous patient with this workflow, which is basically the idea behind it is let's try and do everything that we could do manual, everything that we could do digital, do it digital. So just to recap on what we accomplished. Why would you want to use a large FOV like this? Again, this is the foundation of your treatment plan. You use it to reorient the patient's head, you use it to get the condylar position, and use it to get your cephalometric analysis. Why do you do a 3-dimensional facial scan? It's more dynamic, and it's a more, it's a better diagnostic tool, we believe, than 2D images. The CBCT reorientation and midline identification is really important for us to start the treatment plan. We really need to know where the midline is, where the maxillary central incisor position is, for you to start the treatment plan. Digital Facebook and digital mounting. If we could do a digital Facebook, why do a manual Facebook if you want to complete this completely digital? Cephalometric analysis allows us to verify the vertical dimension, allows us to identify the skeletal relationship of the patient, and to know what the proper angle of the occlusal plane is. Digital occlusal plane with built-in references will optimize the occlusion and simplify the whole process. So that's basically the things that we wanted to cover with this workflow. So I hope this was this was helpful.
It really was amazing. And I mean, absolutely informative. I mean, it highlighted everything. It highlighted the whole digital workflow. It highlighted the fact that, what I liked was that it highlights the basic steps in terms of what you would do to conventionally fabricate a denture, and how all those conventional steps are pretty much on a digital platform. Sam, what we really need to do is that the next webinar that we host, I'm going to get you to come back again, and then I want you to go into R2 Gate, and I want you to unpack. I mean, like today you showed at large, the digital oral design, the whole process, how holistic it is, to the point that you don't have to do any extensive work. You could be designing an upper and lower removable denture for a patient, but you can pretty much design it in a very sophisticated manner, and you can get an amazing end result. But the next time we get you back, I then want to go into the depths of R2 Gates. I want to unpack that software. I want to highlight all the areas in terms of how that software excels. I mean, one of my favorite features of R2 Gates is the way you can pretty much switch on the color, and you can look at the bone densities, and I mean, I'm not gonna give away too much. I'm not going to talk too much around that. I'm going to leave it for another discussion. But I really enjoyed that presentation.
Thank you so much, Sam. All we wanted to say in this is, these are basically my take. This is my take home message. What we wanted to show people in this presentation is, I don't want people to think of this particular software only as a planning software for implants, because the word plan does not only mean implant planning. Implants are only a small part of the whole treatment plan. We saw most of the planning was done before, and for you to just place a couple of implants is basically the easy part. And as you said before, you and Mark mentioned this part extensively, which is treatment planning is essential for you to get a predictable outcome. And you need to see where you're going for you to actually get there. That's the key. Using this software is definitely a skill. So I use the software extensively, and that's why I know how to use it. And for you to learn this software, to learn R2 Gate, digital oral design, to learn DSD, anything else, it's basically a skill. The more you use it, the better you become at it. You have to plan your cases in front of your patients. I personally do that. I plan the cases in front of the patients in order for them to see how much effort I'm actually putting into the case. And for me, it works every single time. So that's what I really love. This technology is already available, so don't fall behind. If you can plan your cases this way, why not use it? The software is there. It's free of charge. You could use it free, basically. Digital dentistry is a daily procedure. It's reliable, predictable, and affordable, and that's what we're doing right now. And last but not least, just choose a system that allows you to apply this digital workflow. These are basically the things that I wanted to say. I also want to thank Dr. JC Kim, because he's my mentor, and he's the one person that puts all his vision into this. And everything that I shared, I'm only a small part in a very big team. And the leader of this team and the vision that we're actually working with is Dr. JC Kim's vision, and I'm super, super happy to be a student of his and developing the software together with him. And last but not least, as you mentioned at the beginning, Sam, we tried to use this time as best as we could. So what I tried to do in the past couple of months is I tried to come up with basically just a playlist that includes everything you need to know about R2 Gate, about digital oral design, and about anything that you will do clinically when it comes to implants or treatment planning. So we made this list. We made a list. If you go to the R2 Gate YouTube channel, under playlist, you'll find a list called R2 Gate and Digital Oral Design, everything you need to know. And in this list, I have 10 videos that go through anything that you want. How do you do the planning? How do you design the guide? How do you finish the guide? How do you design your temporary prosthesis? How do you finish your temporary prosthesis? How do you bond the tie base to zirconia prosthesis? Whatever it is that you need, hopefully you'll find it there. So that's basically everything that I wanted to share. I'm very, very thankful to you guys for actually hosting me here today. And
that was amazing.
It's such a great honor to be with you guys, and I'm super, super happy to be here and to get this opportunity. Thank you so much.
Sam, it really has been an honor for us to have you. And the one thing I want to highlight about everything is the whole concept of communication, and how times have changed, and how important communication with the patient is, and communication with the lab, and communication with your team. And there is no better or more efficient platform than utilizing a digital platform to enhance that communication. For your patient, you know, at the end of the day, it comes down to the fact that we do and we outline extensive treatment planning for our patients, and to have the ability to actually make it tangible to them and to be able to show it, it makes us better clinicians in the sense that we plan everything and we think about things a lot more thoroughly, and it makes them a lot more conscious in terms of what their expectations are and what to expect at the end. And at the end of the day, I mean, the only successful case that you have is a satisfied patient, irrelevant of what we do. The only time you have success in your work is if you have a patient that's satisfied at the end. There's just two questions that have come through that I just want to highlight, Sam. The one question is from Rian. He's pretty much asking, you know, was the process done flapless? And the second question we have is that what was the actual timeline for them to actually mold the denture and return it back to you in Egypt?
Okay, very good. So as far as if the procedure was done flapless, the mandible was actually done flapless. On the other hand, in the maxilla, we usually place the implants first, and then any procedure that needs to be done afterwards, I open a flap and I add, do an augmentation or whatever it is that I need to do. The reason why I open a flap after I place the implants is because I don't want the placement of the guide to change, because this is a tissue-supported guide. So if I open a flap, the placement of the guide will actually change, and it's not going to seat exactly the way I want. So I just want to get the implant placement done correctly, and then any other procedure that needs to be done later on will be done, but just after we place the implants. That's the first thing. As far as how long does it take to actually mill the denture, that I actually don't know. I'm not involved with the actual technical process when it comes to Avident. I'm going there to get more information about this.
Sorry, Sam. The actual turnaround time, if we had to send it from South Africa, for example, to be milled, what would be the time frame that we would look at in terms of?
I believe in my case, I actually received it in Germany because it's a lot easier. We go to Germany every month, as we said, and it takes just a day for them to send it. I think it takes to actually, I think the turnaround time might be a week to 10 days max. That's as far as I know. But I need to make sure before I provide this information.
So once again, Sam, I mean, there's just a wealth of knowledge, and I think today people got a glimpse of some of the conversations we have and some of the stuff that we talk about. I think they've really got a glimpse of it. I mean, a little bit of background at Sam and I, when we get onto a webinar or when we get onto a Zoom call, it generally lasts at least 2 hours, and we've got to say, okay, fine. And then there's a phone call after that. So I think people have just got a glimpse into your knowledge and your base and your expertise in the field. And we've unpacked one small part of it. And I think as these webinars unfold, I'm definitely, I'm booking you in advance for the rest of the year, as you know. And once this whole lockdown is over, Sam's going to be joining me at the clinic, and we're going to go from start to finish with one of those cases. We will plan it all the way through, and then we'll probably look at creating a live stream onto the Facebook page and take you guys through that whole journey. So, I mean, some really super exciting stuff lined up in the head. And once again, Sam, I mean, we can't thank you enough for sharing all of this with us, and for putting in all the time to create all those videos on the YouTube channel. So, you know, go access that content, access the information, and it's all there. Mark, any comment?
I mean, no, just like staggered about the knowledge and the skill and the information that you have, Sam, on the subject of digital. And I think that you've realized, and so have us, that it's what our patients really deserve. That all of us, even with huge experience, can have a bad day. And so the more we can work in a guided way, the more we can make mistakes digitally when we're planning rather on our patients,
I
you know,
agree.
the better off dentistry is going to be. And so,
Yes.
you know, this is taking away, as I say, those little mistakes, those little errors that we see creep in. And the more I can do in a guided way, whether it's orthodontics, whether it's prostho, the better I feel. And honestly, I think the time will come where our patients will demand that implants are placed in a guided way, that whatever it is, that there's more control in dentistry. So, you know, and I see this happening very quickly, you know, so I think that it's a win-win.
You know, as you mentioned, Mark, you know, even with your experience and with Sam's experience and with you guys that have a lot of knowledge when it comes to clinical and digital, sometimes you could take too long in a procedure. Things might go wrong. But for someone like me who's not a talented clinician, at least when I do everything guided, just guided is only a way for me to make less mistakes, or at least to, you know, the word predictability is basically the word that we're looking for. We're trying to make things a little bit more predictable. So again, I just try to do things in the best way possible, and the best way possible, I believe, is to do them guided to compensate for the things that you lack. But that doesn't mean that, you know, clinical
I disagree, Sam. The more time you spend clinically and the more experience you have clinically, the more you want to do things guided, and the more you realize how super, super important any treatment planning, any guided treatment planning is. There's no ways you get to a point where you can do things with your eyes closed anymore. And I think all the experience does is the experience pretty much guides you to guide the guide. Mark, how do you put it? I love the way you put it in terms of you've got to speak for that.
Someone needs to guide the guide. You know, we still need to make clinical decisions. We still need to understand what length or what diameter implants we're going to place, and why we're going to place that length and that sort of implant, why we're going to do this type of tooth preparation versus that type of tooth preparation. So, you know, the clinical decisions are made in the planning stage, not when the patient's sitting in the chair. That's the difference.
And, you know, it's that whole tactile feel, you know, like sometimes you look at the CBCT scan and it tells you that there's D3 or the bone type is D2 or whatever it might be. And you get in and suddenly you're surprised, you know, you're drilling through D1 and D2, whereas the scans pretty much indicate D3, D4. So it's that tactile feel, it's that sensory input that you get. And I think if anything, you know, guided and digital workflow and digital planning is pretty much the future. So on that ending note, thank you once again, Sam. Next week we have Eduardo Mon with us from Chile. I mean, also super excited about that. I mean, that guy I can't keep up with. In the last like 9 or 10 months, there's been like 4 or 5 publications that have come out with his name behind it. So I mean, we're really excited about it. I mean, Mark is a good friend of yours as well, but such a super humble human being, like Sam, and super smart guy as well, like Sam once again. So we really look forward to it, and we hope to see you guys back on the page next week Friday.
Thank you so much.
Thank you so much.
Have a good evening.
Cheers, Sam. Have a nice weekend.
You too.